Hello, and a big welcome to the eCancer learning session at the Prostate Cancer Roadshow in London. We've just had a really interesting session discussing advanced prostate cancer, and I'm really happy to be joined by my colleagues this evening, Professor Kurt Miller, who is a urologist in Berlin, Miss Netty Kinsella, who is a nurse consultant at the Royal Marsden Hospital, and Professor David Dearnaley, who is a clinical oncologist at the Marsden Hospital as well. So we have a great panel here tonight, and we would like to share with you some of the discussions that we've had this evening. Starting with diagnosis, Netty, how do you think this has changed over the past few years?
Well, I think certainly the PROMIS trial has contributed to a big change in the way we think about diagnostics. Multiparametric MRI and MRI fusion prostate biopsies have really been pushed to the forefront of diagnostics, and I think actually the emphasis is much more now on making sure that we can take men off of a diagnostic pathway earlier, that we're not biopsying men that probably are going to be diagnosed with very indolent disease that possibly never needs diagnosing, and actually are concentrating on those men that need a diagnosis and need radical treatment.
And how do you think active surveillance has sort of changed our management of early prostate cancer?
Yeah, well, I mean, I definitely feel that active surveillance is still going to be an important part of the options that we give to patients. I certainly think we're closer to an idea of what safe active surveillance might look like in the future, and I think that's come about as we've got better diagnostic tests and we're being more accurate with our diagnosis, certainly with staging disease. But I think active surveillance in general is one of those things that really, as clinicians, we need to be shouting about a lot more for patients with very low to intermediate risk disease, to ensure that we're not suggesting that men have to live with the morbidity of some of these radical treatments for long periods of time, even if it is as more of a stopgap to preventing people from being treated too early.
Lots happening in early localised disease. Kurt, what do you think about new diagnostics for more advanced disease? What's happening there?
Yeah, we've seen similar developments for diagnosing more advanced disease. I think we had the first step with whole body MRI, which probably was kind of an intermediate tool, so to say, because the data are quite impressive, but it's probably never been used very broadly, at least not in our surrounding. But then along came the PSMA, PET-CT PSMA as a tracer, and that gave us, in comparison with the older diagnostics like bone scan or colon PET, a real step upward in terms of sensitivity and also specificity. So we've been talking about oligometastatic disease. So oligometastatic disease 10 years ago with the bone scan is probably not the same as oligometastatic disease today with the PSMA scan. So it also may, as Netty just has said about MRI, it may change the way we're treating and looking at prostate cancer.
Does everybody have access to PSMA scanning, or have you found it a useful tool?
It's not got universal coverage in the UK as yet. It's not the easiest tracer to handle. It's got a short half-life, etc. So it's something that will develop, and as it is more clearly shown to be beneficial, as it's shown that it actually does change the management of individual patients, then I think it's going to become a requirement, or something similar to PSMA.
Because there are new tracers coming.
Yeah, there will be new tracers, but I think it's a step change in the diagnostic accuracy we've got for finding metastases in men who have high-grade locally advanced disease, as well as in detecting very small volume disease in men who have recurrence after either surgery or radiotherapy.
And in what ways do you think, we've talked quite a bit this evening, or you've talked to us about oligometastasis, which has been fascinating, and how could you just summarise for our audience how you think that's going to change our practice in the next 5 years?
I think our practice will really only change if we do the proper studies to find out actually whether treating oligometastases really works and has an impact.
Because it's very attractive,
It's a very obvious idea, and it's a very attractive idea, but does it really make a difference to patients? The data that we've got at the moment suggests that there will be about a quarter to a third of patients who'll get long periods of disease control, perhaps even cure, just treating the oligometastases without a need for systemic treatments, either with hormonal therapy or with chemotherapy, both of which are associated with a much higher side effect profile. So I think it's quite exciting, and I think we are going to learn a great deal of interest. But I think it's also very important, as Kurt has been saying, that we use the diagnostic tests appropriately. This is going to impact on actually the proportion of patients who end up being curable or having long-term benefit. Very exciting time. And we've got the tools to actually deliver the treatments. Used to be just CyberKnife. Now a whole range of different radiotherapy equipment can do it. But we shouldn't forget about other options. There will often be a surgical option, and there are other kids on the block, things like high-intensity focused ultrasound for treating bone metastases, for example. So it's a range of focal modalities, and we need to be able to choose the best one to suit the individual patient.
Yeah, thank you very much. And I think radiology's almost become another biomarker now, isn't it? It's a way that we're going to determine treatments. Kurt, what are your thoughts on some of the other biomarkers? How are they going to change practice, do you think, over the coming years? Because at every meeting we talk about personalised medicine and...
Yeah, actually, for the time being, for prostate cancer, we do not really have precision medicine, as it's called, because none of the biomarkers we had so far, and for example, ARV7 was, there was some hype like 2 years ago, and then it turned out that it's not as good as a negative predictive marker as it seemed to be at the beginning. And this is a nice role model. We
were
not in a way.
About
no,
it,
yeah, we were excited, and
then
then it turned out, well, it's not as good as we thought at the beginning. Anyway, but this is definitely the way for the future. And to mention like DNA repair deficiency as a marker for PARP inhibitors like BRCA2, BRCA1, ATM, and we've seen in phase 2 studies that this is kind of predictive for certain types of therapy as PARP inhibitors. And this is only one step, and I think we certainly have made progress in terms of new generation sequencing, but it's not there yet. But it will change the way we treat this disease, I would also say, for the next 5 to 10 years or so, because then it's more like the genetic signature rather than the organ specificity in a way we treat the disease. I mean, we've been talking about this for a long time, but we're much closer now to that. I would think that like 10 years ago.
Netty, what do you think? I mean, these are sort of very exciting times for men, I think, with advanced prostate cancer. What general advice would you give to patients when they are first diagnosed as they're facing treatment with ADT and other therapies?
I mean, the most important thing, I think, is to actually approach each of the treatments that you might be offered in bite-sized chunks, because I think it's very easy to think about the next treatment while you're on one treatment, because we do have this feeling that things have a shelf life or there's a timeline associated with the treatment. So it's all about putting things into perspective and actually trying to optimise and maximise your quality of life while you're on each individual treatment. I mean, certainly For example, if a gentleman's starting ADT, I mean, there's very key lifestyle associated advice that I think is really important for us to share with our patients. And I think it's a joint responsibility of nurses, oncologists, urologists, in order to be able to deliver that. But I think it really helps patients to really feel a part of their care if they're actually doing something proactive towards living a healthier lifestyle and being much more engaged in their cancer treatment.
Yeah. Definitely. David, what do you think about guidelines? I mean, we have lots of guidelines, don't we, and guidance. Which do you think are the best guidelines to look at to get advice for almost the menu of opportunities for patients?
I think there are a variety, and one of the important things is that they're kept up to date. I think the European guidelines are pretty sound. I think the North American guidelines are also have got a huge amount of merit to them. There are different flavours, of course, because different treatments are available in different places.
I think that's very sort of sound advice, and as we've been talking about today, it's also the individualised options for each patient and their own sort of personal circumstances. But I think it's good to have some basics from the guidelines, which we sort of base our multidisciplinary discussion.
Yeah, I think it is. I mean, the problem with a guideline, of course, is it can't become a guideline until there is adequate evidence to support it. So
Yes.
many of the things that we
Yeah.
are very interested in discussing and speculating about from the future can't be in a guideline.
Yeah.
Except that you can say we ought to be doing more research in this area,
Yeah.
and that's a great guideline.
I think that's good. That's good guidance for anybody, isn't it? Really. That Kurt, we're talking about new developments. At one stage, hormone-sensitive prostate cancer was sort of orchidectomy, ADT, but we've had some great results in the last few years for changes in hormone-sensitive disease. Could you summarise those for us?
Yeah, first step was that the addition of chemotherapy, specifically docetaxel to ADT, proved to be much better than ADT alone.
That was surprising.
Yeah,
wasn't
that
it, really?
we did, I mean, there were some very old actually data comparing, like I think mitoxantrone or epirubicin with ADT, and they showed similar things, but that was 20 years ago, and it started all with the JETOC study, and it was negative. And for me personally, I thought, okay, that is gone. It's there's no more progress here, and I turned out to be wrong. And then that was 2015, and then 2016 we got the STAMPEDE data. In 2017 we got additional data with abiraterone plus ADT, so some kind of a super combined hormone blockade for the patient, and it showed pretty similar results to the as chemotherapy. And so we're now in a situation where we have really, really new options. And the interesting thing is what David mentioned, that we have now the possibility to locally treat these patients, metastasis and the primary, and we have also new option to systemically treat these patients. And it's hard to say who is good for what. It's again about precision medicine currently. So the good thing for the patient is anyway, we've made progress in both ways.
Thank you. David, what's your tip for the future? What do you think is going to be important in the next few years?
I think bringing forward our new treatments into locally advanced disease, the new treatments we have are really good for patients, but actually they don't cure more patients. If you want to cure more patients, you need to go for the group that are on the borderline of curability, and that's locally advanced high-grade disease. And I just reiterate Kurt's comments about the use of chemotherapy and abiraterone in this group, where the results are truly spectacular in terms of reducing recurrence. We've never ever seen anything like it.
No.
So I think there is going to be a new curable subgroup, and this subgroup is going to be comprised of patients who had a very high risk of dying of prostate cancer, rather than very early prostate cancer, where actually our treatments aren't affecting mortality very much, because actually the men are not destined to die of prostate cancer. So I think that's very, very exciting. But what we would need to do is to work out which modalities to combine in that group, because we are, after all, curing quite a lot of them already. So we don't need any extra treatment, but we don't know what that group is.
No.
So this is where the personalised treatment comes in, and whether it can be done by the molecular marking of the primary tumour, or whether it needs to be done using circulating tumour cells and enumerating the different types of cells that we can find, and how, for example, how androgen receptor expression varies in these cells, is something that we need to work on. But I think it shows great promise.
So I think that's a great note to end on, because there is such promise and excitement for the future of advanced prostate cancer. And I'd like to really thank my colleagues for sharing their wisdom and experience. I'd like to thank you very much for joining us this evening. Thank you.